placebo effect occurs when people do not receive the active treatment but show an effect. The placebo effect basically is a situation in which responses are influenced by a participant's beliefs about the treatment, whether those beliefs are positive or negative. So on the right hand side of the screen you see here an example of what a placebo effect looks like. So this is an example where we're interested in the effects of alcohol on driving errors. And we have three groups of people. One group drinks alcohol, one group drinks placebo alcohol, and one group drinks juice and they know it's juice. Okay? And so the idea is for both the alcohol and placebo alcohol, they think they're getting alcohol. So we look at the number of driving errors. What we find is that between 0 and 20 minutes, the group getting the real alcohol shows progressive increases in driving errors. The group that did not receive alcohol but thought they were getting alcohol is also showing driving errors, although not as much as the real alcohol group. And the group who got juice and knew they were getting juice is basically showing no driving errors. And so this difference between the juice and the placebo alcohol condition suggests that believing that you're getting alcohol can produce increases in driving errors. And that is what we're talking about when we talk about a placebo effect. So to drive this point home more, let's take a quick look at this video, which I think does a fantastic job of driving home the point about
now, you've all heard of the placebo effect before, when something with no known therapeutic value can actually make people feel better. It's a great trick our minds play on us, that by believing and expecting something to work, it actually does. But what's weird is that the strength of the effect can differ for some really strange reasons. For example, the same placebo can treat pain half as well as aspirin, while at the same time treating pain half as well as morphine. Morphine is a much more powerful painkiller, but a placebo is half as effective as both. Saying a placebo will reduce pain reduces pain, but saying that the same placebo will increase pain increases pain. Believing that a placebo will make you feel better will make you feel better. Believing that it won't has the opposite effect. Now, placebos aren't just pills. They can be creams, injections, surgeries, or drinks. You can even get placebo buttons. They don't actually do anything, but they sure as hell make you feel like you're in control. But not all placebos are equal. The effect of the placebo is bigger when the pill itself is bigger, or if you have 2 instead of 1, or 2 once a day instead of 1 twice a day. And a capsule will usually beat a pill, and a syringe will usually beat a capsule, and anything with a big ass science machine can outperform any of them. A plain pill works worse than a branded one. A discounted pill works worse than a pricey one, and even a pill in a plain box does worse than one that's all shiny and shit. Placebos that are blue work best as downers, and placebos that are red are better as uppers. Studies have shown that people who take their meds on a regular basis are less likely to die than those that don't, even if those meds are all placebos. You can even get addicted to placebos. In one study, a group of women took placebos for more than 5 years. 40% of them suffered withdrawals afterwards. In fact, the effect of placebos can be so strong that some people want them banned from sports. But I mean, how would you even test for that? Placebos don't even seem to work from place to place. For example, in Germany, using a placebo to treat ulcers works better than anywhere else in Europe. But using a placebo that treats hypertension doesn't work nearly as well as it does for its neighbours. Now, remember that All of this is about comparing things that both have nothing medically effective in them, which goes to show that a placebo isn't about what's in it, but about the beliefs that we load onto it. Our minds create the medicine, and that is pretty freaking weird.
Okay, so that is a great video showing you exactly how the placebo effects work. And so placebo effect has been measured in thousands of clinical studies. And studies basically to get for a drug to get approved, they have to show that the new drugs work better than a placebo before you can get approval. Placebo has been shown to affect a range of health conditions. As you just heard, the color and size of the pills can alter the strength of the placebo effect. Injection usually trumps a pill. And a lot of times we see the biggest effect for placebos on self-reported outcomes, but we also see it in terms of influencing biological outcomes. And one great example are studies that have done sham surgery. So people either get a real knee surgery or they get a sham knee surgery. And some of the studies that have looked at this have also found that just getting the sham surgery can result in placebo effects. So placebo effects are real, and they can play a big part in terms of the difference between the effect of a drug and no effect of a drug. So the bottom line is we have to be very careful about the degree to which a drug is working just by placebo effect. And a great example of this, I think, right now is CBD or cannabidiol. And it's not entirely clear, what part of that effect is placebo and what part of that effect is actually cannabidiol. So how does this work? It's basically based on expectancies, that when you expect a pill or a drug or a cannabinoid will do something, you're much more likely to report that it does. And that's all based on the fact that you expect it to work. And so when we look at something like antidepressants, for example, scientists estimate that about as much as 50 to 75% of the effect of an antidepressant is due to a placebo effect, is due to our expectancies or beliefs about the medication. So that's the reason why the highest quality studies usually include a placebo condition. Now here's where it gets tricky. Just including placebo doesn't mean your study is placebo controlled. The problem there is if it's easy to tell if you're getting a placebo or the real medication, the placebo is no longer effective as a control. You have to actually believe the placebo is a real medication. If you are in a situation where you can't put together a study, so as a quick example, THC, most people know when they're getting THC, so placebo doesn't really work. In that case, the best idea is to have an active control condition. So for example, in some of the work looking at ketamine and depression, rather than using a placebo, they used a benzodiazepine so that people felt a little loopy and couldn't tell the difference between ketamine and the control condition. In that case, the benzo worked as a very nice control to ensure that any effects of the ketamine was actually due to the effects of ketamine and not expectancies. So a couple other important terms here to understand. Single blind means that only patients are blind to condition. And the problem there can be sometimes there can be nonverbal cues that can tip off the patient so they're not blind anymore. Double blind means both the doctor and the patient are blind to what they're getting. So the doctor doesn't know if they're getting the real medication, and the patient doesn't know if they're getting the real medication. And then finally, random assignment to condition basically means that we are randomly assigning people, as we talked about in the last lecture, to different conditions of the independent variable. So our designs that we've been using in our research, typically we don't use a placebo. Rather, what we do is we compare CBD only or CBD to CBD dominant products to THC plus CBD products to THC only products. So the problem with the placebo in our studies is that when we have THC, it's pretty easy for people to know whether they're getting THC or they're getting a placebo condition. And in theory, a study that involves all three of these conditions probably has equal expectancies across the three conditions. So people have positive expectancies about all three of these. So the other thing here is that it's hard to make patients blind because, again, they're going to probably know whether they're actually getting THC or not. So it's difficult for people to be blind. And then finally, one of the reasons we don't randomly assign people to conditions is because if we did, it would trigger FDA review, and the FDA cannot approve something that's not federally legal. So it really restricts us in terms of not being able to randomly assign people to conditions. So this is very important. This is a heuristic that I pulled from the Oxford Center for Evidence-Based Medicine. And it's basically a rubric for how to grade evidence. So here you see in this table level 1 through 5 and the type of evidence we're talking about. So level 1 is the strongest evidence. We're talking about randomized controlled trials with large sample sizes. One step down from that in terms of the strength of evidence is a large study with a control group but without random assignment to condition. And one step down below that is a smaller study with controlled conditions. And then at grade or level 4, we have a study without controlled conditions. And then the last, least reliable level of evidence is either expert opinion or anecdotal evidence or evidence solely from biological research. So this is a nice thing for you to remember in terms of understanding which studies are the strongest when it comes to the effects of cannabis or cannabis products. In conclusion, the placebo effect is real. It can have a substantial impact on a study. And this is true for cannabis and CBD, but also true for every proven medication. So pretty much anything you look at, antidepressants, for example, anti-anxiety drugs, the placebo effect is real and can have a pretty big impact in terms of the outcome. Placebos are helpful to the extent that people cannot distinguish placebo from real medication. And ultimately, when you're looking at studies as a consumer of the evidence, it's important for you to understand how to grade studies in order to understand the strength of the evidence, in order to understand how much confidence to have in the conclusions of those studies. As a quick discussion or reflection point, here's some questions for you. How much of a placebo response would you expect with a cannabis trial? Would you expect the placebo response to be equal in CBD only conditions, THC plus CBD condition, and a THC only condition? In other words, do you think people have equally high expectations of each of those conditions? And how much does that actually matter?